Hospital Kakinada, welcoming you all on the behalf of Trust Hospitals to our CME. And second in the series of discuss by design CMEs for us. So last CME which we did 3 months ago under the same heading, we focused on non-invasive cardiology, risk assessment for coronary artery disease and stress perfusion imaging were the 2 topics we covered last time. So in continuation with that, we have planned this CME to give a little bit of focus on imaging in cardiology. Now, cardiac imaging previously, which was just limited to the echo lab, is now expanding rapidly with CT, MR, and stress tagging and perfusion imaging. So among these 3 things, if you put MRI to aside for the time being, we have picked up 2 topics for today. One is CT coronary angiogram, 2 is viability assessment. CT coronary angiogram will help us decide whether a patient requires an intervention or not. And viability assessment will help us decide whether the patient will benefit from the intervention or not, in a gross way. So, in order to kind of expand on these topics, we have actually sought out the best people who can actually enlighten us with regards to the nuances of these topics. So, we have 2 guest speakers today. The first person to talk about CT coronary angiogram will be Dr. Ramesh Babu sir. We asked Ramesh Babu sir to come on the stage. Dr. C. Rao sir, Chief Cardiologist, Hospital Vizag. So we'll start the presentation, and I request Dr. Chandramouli to give a brief introduction regarding the biography of MS.
Thank you, Nisha. See, he is a master class in everything. Like during his academic career, right, his professional career, everything. I think everybody knows what Ramesh Babu sir is. So only thing I want to just say only one thing. For the last 1 year I am seeing him. He is a good human being, basically. Only one thing I just want to say, he is a good human being. That's what he is very considerate towards his patient, and his patient care is excellent. Till now he is maintaining his standards, and that's why he is flourishing. Thank you, sir. And thanks for giving me the opportunity to work in your good institute, sir. And regarding today's topic, this is the first topic in the series of preventive cardiology. So sir has vast knowledge and vast series of patients regarding this CT calcium score and CT angiography. So he has presented many papers and has done a lot of work regarding this. So hope everybody enjoys his talk and will be enlightened by his talk. So I welcome Dr. Ramesh Babu sir.
Thank you for the kind introduction, Dr. Chandramouli. At the outset, I would like to express my sincere gratitude for the kind invitation extended by the Trust Hospital management, especially Dr. Nishant. And I'm very happy to share this evening with my friend Dr. C. Rao. Many years we know each other, though we don't meet very frequently. And the senior physicians here, the senior practitioners, the youngsters, the students. I heard Kakinada is a very cool place. I enjoyed my drive from Vijayawada to this place. Today's topic is very close to my heart. At the time, in fact, I was talking to the speakers also. All the studies, the trials which are done, and with a lot of controversies, most of the times the endpoints were, mortality, cardiac mortality, but without knowing the coronary angiographic picture, hypertension, this drug, that drug, diabetes, lipids, but without knowing, because the personalized medicine or the segregation bias and a lot of things were there, and there is no other field in medicine other than cardiology where there has been a lot of controversy since 1960s, right from intensive care unit or domiciliary care, and aspirin, then dipyridamol, a lot of other drugs, the devices, the treatment, even a number of issues are unresolved and open for debate between the cardiologists and surgeons, as you know. And still there is a black box, a gray zone in the field of cardiology, which will be seen in my presentation. So we started cath lab in 1996, and our team of cardiologists, we have conducted more than 1 lakh of invasive coronary angiograms and over 20,000 CT coronary angiograms. So, in fact, I was the person who was pushing, though my colleagues were not very keen in the initial phase, and till now it is globally accepted in the past 1 year. So, before starting, try to just pose some, day in and day out problems and concepts which we have while practicing cardiology. General physicians or any practitioner for that matter should necessarily possess some degree of knowledge in managing chest pain, acute chest pain, chronic chest pain, and screening for coronary artery disease. And though we don't follow those colored charts regularly in our OPD, all of you are aware that when we are sitting in the OPD, when we want to screen a patient, so we would like to have some idea what will be the risk score in this patient based on the data available from, not from India but from other countries, UK or US, Australia and European countries. So, which risk score closely is applicable to Indian patients, if at all. We will go through that later. And then how far our assessment, we as physicians, as practitioners, when you see a patient, you suspect coronary artery disease, you refer to a cardiologist. When do you do that? Is it based on some calculation, math? And how far with the available practicing guidelines we are, appropriate in referring for screening and interpretation. So how frequently we are right. Then all of you are aware, even in MBBS and all, this is a very, very common investigation. Ischemia stress test. In fact, 1980s, when I was a student, first year student, I was posted in a treadmill room, and I still remember, we were thinking that treadmill is the test which can definitely pick up or identify coronary artery disease, based on which we used to refer the patients either for medical management or invasive angiogram, or interpret in our own way with the available knowledge at the time. After that, we have several other ischemia stress tests, radionuclide stress test, Doppelmayr in MRI, Doppelmayr in echo test, likewise. And it's considered as gold standard till very recently. So what is the downside and what are the debates? Dr. Rao will discuss about the viability aspect, but coming to the reversible ischemia, mild, moderate or severe, based on which we used to recommend therapeutic modalities, whether going for intervention or medical management. Now we have a big question mark there, whether the patients will really benefit if you advise interventions based on this stress test result. And now mild, moderate or severe, what is the significance, and if you advise PCI or CABG based on this, really are we going to get the desired benefit? Is it equal with PCI or CABG? And we were all doing, as cardiologists, a lot of mistakes, in a sense that since 1996, when we started doing invasive angiograms here, we used to see many patients with 30%, 40%, 50% lesions. So when we suspect and find this, we used to tell nothing is there and you don't need to worry. We also have, similar blocks at some age and all. But now we know what exactly is subclinical atherosclerosis, how is it important in acute coronary syndrome or sudden cardiac death, which we have been seeing day in and day out, and apparently physically fit, very healthy people, and the subclinical atherosclerosis, which is hidden, unidentified, is seemingly responsible for these sudden calamities in the families. Now, we also used to think that whenever I get a call in the emergency room, midnight, 1 o'clock, patient complains of chest pain, I'm biased, immediately ask, what are the risk factors? So if the medical officer says, no risk factors, hypertension, diabetes, it gives a sense of solace. Oh, it may not be. But now we know, as I'll be showing, in acute chest pain or acute coronary syndromes, the risk factor profile doesn't really help us in striking a diagnosis or making it, reaching a judgment. And coronary artery calcium, though it is known for almost 30 years, a lot of time, lot of debates in the past decade, almost contradicting, ruling it out, not really helpful, more radiation dose and all. Now, in the past 2021 August, almost all the societies across the world have accepted that CAC is a it is the best modality to pick into the coronaries to make an anatomical diagnosis rather than a guesswork of a stress test or risk factor stratification. And also, when CTCA was introduced and then the iterations, the modifications, innovations are coming up, there has been a huge controversy, debate. What is the reliability, accuracy vis-a-vis invasive coronary angiogram? Now we know that it is 97% accurate, and the other, the usage of statins based on these risk factors, and then the radiation dose is another important factor which is discussed, for the past 10 years. And is it really high or lower compared to the invasive angiogram? We have a lot of data accumulating on that. And then complications like dissections and all with invasive versus the CT angio, the benefits and all. And then these are the other things which will be in course of time we'll see. And ultimately, in fact, I have been going to the physicians conferences and IMAs, trying to impress upon that it is the general physician or the family physician who is responsible, who should take the onus of preventing sudden cardiac death or acute coronary syndrome, not just referring the patient to the cardiologist, following the patient for 10, 15, 20 years of diabetes, hypertension, just treating these, and then only when the MI happens, the patient is referred. It means we have been missing subclinical atherosclerosis, golden opportunity to diagnose the hidden disease and treat and prevent or postpone the disease, acute coronary syndrome or sudden cardiac death. So, misdiagnosis in coronary artery disease, misdiagnosis and missing the hidden heart disease is one of the major problems which is happening, which has been happening, which continues to happen unless there is awareness which is created and proper modalities which are available. Not only the hidden heart disease, misdiagnosis of chest pain in the emergency room. It is quite common. Misinterpretation of the ECG, because first ECG in the first 1 hour is normal in almost 45% of the patients with acute myocardial infarction. And the location, and 40% of the acute myocardial infarctions are silent or they have very mild, vague symptoms, some fatigue, some palpitation, especially in females, and syncope or giddiness sometimes. So misdiagnosis is still, and delayed diagnosis, missing the golden hour, still still continues to be very, very prevalent in a country like India. Then, as I was mentioning, the role of risk factor stratification, the ischemia stress testing, and the invasive coronary angiogram, which all of us have been doing for decades, which is considered the gold standard. Is it really the gold standard for diagnosis? For interventions, okay. Is it still, or it has got some fallacies? Then, what is the usage of statin? Is it, do we have very clear guidelines? The global usage of statin, how is it? Is it at least appropriate? Or how frequently we misguide the patients because the available guidelines say either you take the statin or you don't take the statin, and how frequently all the cardiologists across have been wrong and continue to practice still with the border guidelines. Then the CT coronary angiogram and calcium score have entered into the emergency room also. Acute chest pain is something, unless you are very cautious and in approach, you can miss, and that can damage and hugely damage, cause a lot of discomfort to the family also. So the role of troponin and the role of CT coronary angiogram and certain scoring system like heart score, how you apply in acute chest pain patient so that the misdiagnosis is less than 1%. Good institutes have, misdiagnosis has come down to almost 0.1, 0.2%. And then there is an interesting concept of CAC 0, coronary artery calcium 0. 0 is something like, it is priceless. A person has got a CAC 0 compared to a person CAC 1, CAC 100, CAC 400, CAC 1000. Even CAC 1 is dangerous because CAC 1 means already there is a plaque. CAC 0, yes, patient may have it 0 for the next 15-20 years based on several factors, genes or whatever. So CAC 0 has been talked of quite a bit, though the limitations I'll be talking about in our country or wherever it is, though it has limitations you have to interpret. And then a lot of dilemmas in therapeutic strategies, which I will not be discussing now. And it is not surprising, the accumulated evidence has resulted in guidelines in 2021, wherein almost CT coronary angiogram has replaced the invasive coronary angiogram, risk factor stratification, ischemia stress testing in almost all the groups of patients, asymptomatic patients, patients with non-anginal chest pain, patients with stable angina pectoris, patients in acute chest pain. So every group of patient, unless it is a STEMI, wherein directly you take the patient, you give thrombolysis or take the patient to the cath lab. Almost every other patient, when the troponin is negative, even if you see the patient in the ER, you assess the risk, low, intermediate or high risk, and majority of the time CT gives you the answer, what the line of treatment you have to adapt. Now, since I was student, 1980s, we were thinking, yes, treadmill positive, there is a lesion, 80%, or 70% in important vessels, patient should be revascularized. That is the concept which we were having. We were seeing the surgeons when even PCA was not available. We were seeing the surgeons operating on a right coronary artery 70% block because that was the concept. All of us are thinking if it gets blocked, patient may die. So we were predominantly focused on the lesion severity and how early, how best we can revascularize to save the life. But now, slowly, the concepts of vulnerable plaque, then the Myocardial ischemia by stress testing and its limitations I'll be talking, and then the role of inflammation, then the vulnerable patient concept, and of course the FFR in the past decade, FFR, IFR. So the role of it in assessing so that the tubular vision is not there and you try to assess the hemodynamic significance of a lesion. And now we know, as I've been mentioning, it is not the degree of stenosis, but it is the total atherosclerotic burden and the proneness of the plaque to rupture, so-called high-risk plaque, and the disease activity, inflammatory activity, and the prothrombotic milieu. All these factors put together result in the progression of the disease or sudden ASCVD events. So we are focusing on all these things rather than being, confined to the lesion or degree of stenosis, which we were doing it earlier. Now we know this is a pandemic. India is the capital for coronary artery disease, and unfortunately, we talk a lot about symptoms when we, as cardiologists, also debate conferences. We keep talking about symptoms, presence of symptoms and all, but we know that almost 40% of the myocardial infarctions are asymptomatic or silent, and majority of the time they have atypical symptoms. So now we have data on that also, how frequent is coronary atherosclerosis in absolutely asymptomatic patients between 45 and 60 years. I'll be showing the data. So how this specific group, which is still debated, which is still controversial, needs to be addressed. And almost 50% have, and then it is going to be the capital, and then the huge cost, it is obvious, the impact of it. And then, can we predict this dreaded coronary artery disease? Can we predict and prevent? With the guidelines which were there till a year back, it was almost impossible, and many of the people who were looking very fit, we lost them. And this is not a recent one, only in the past 1 year, 1.5 years, when the celebrities' lives are lost, now the global attention was there. But then this is not new. All these people who were very fit and then died at very young age, including a very famous cardiac surgeon, Dr. Ramakrishna, would know about him. So we were discussing also Nitu Manke, who constructed a hospital, I think, Kakinada Hospital. So this sort of sudden happening without warning signals has been happening for decades. But somehow all our cardiologists in 2000 and in the past 2 decades, we were all focusing on degree of stenosis, reversible ischemia, then revascularization, new air stents, new air CABG techniques. But we were not really, the cardiology community was not really focusing attention on hidden atherosclerosis and primary prophylaxis, preponing the secondary prophylaxis by identifying the disease. And there probably a lot of delay has happened in the past 20 years, though there is substantial evidence which has accumulated over the past 3 decades that more attention should have been paid. And acute myocardial infarction doesn't happen overnight, as many people think, and as the general opinion, public opinion. It takes pretty 15-20 years from the fibro fatty streak, monocyte infiltration, LDL ingestion, and then oxidized LDL, then release of cytokines, then endothelial dysfunction, vascular smooth muscle coming in, and then calcification, microcalcification, macrocalcification. And this was known even in autopsies, Korean and Vietnam War autopsies. The lesions were in the mean age of 22 years. Lesions were there, significant lesions, in almost more than a third. And almost all of us have been looking at different angles based on the expertise, availability of equipment, interpretation, and socio-demographic conditions we were trying to do and trying to figure out. And we know the family physicians treat these patients for years together, and we tend to see only a thing when there is an acute event. So the reason why I am talking, in fact, out of 1 lakh angiograms, maybe I must have done around 40,000 angiograms, invasive angiograms. But if you ask me now, yes, this patient has got hypertension, diabetes, okay, he has got some chest pain, now he is going to cath lab. Can you tell me whether he has got 1 vessel, 2 vessel or 3 vessel disease, and what will be the degree, whether he will require any revascularization, intervention? I will not be able to tell, because it is so uncertain. The predictability and the even presence of the disease and the progression is so uncertain. And all these patients, like 51-year-old, treadmill positive, hypertensive, family history of CAD, before entering we would think at least 1 vessel block would be there, and patient has got normal coronaries. Similarly, 60-year-old, family history, hypertension, diabetes, these normal. Likewise, I can show you hundreds and thousands of patients like this, where we took the patients for invasive angiogram, where we got the radiation and the cath lab staff have got the radiation, but still we just pat the patient, okay, it is normal, right? But now we have tools where we don't need to get the radiation. The young cardiologists don't need to get the radiation, and the uncertainty and then the genetic role, the environmental factors now are also recognized to be important. So they have a predilection gene. Some people who have major risk factors, and they don't develop after 20, 30 years also. We were all perplexed, we were all surprised. We were thinking that nature is protecting. But this has been happening, and so many patients. And sometimes patients come with shortness of breath. Many times they don't go for any investigation because ECG is normal, shortness of breath, young patients. We also don't push them for invasive angio. But when you have CTCA, many times, not uncommonly, we find very critical disease and mild SOB also. Sometimes patients complain and then next day they succumb. So atypicality of the symptoms, a number of patients we have seen like this, and then this young guy, is 45-year-old, see the calcium, whole of it. So the almost more than 3,600 at the age of 40, 45. So we do not know why. There is probably again genetic predilection even for calcification. And this is another interesting case. I was telling the prediction and the progress of the disease also we cannot. So this is one of my friends, obese, smoker, diabetes. So he just got it done because he was having breathlessness. In 2013, we did his CT. It was showing around 40-50%. So he was mentioning, he was my friend. So he said, no, if there is any doubt, you don't go for this tent because I have a lot of business work and all. So, but then we said, stop smoking, do some exercise, and then control your diabetes. He didn't do anything. Then at the end of 5 years, I, with great concern, I did the CT. Then it disappeared. So we don't know why it happens in some people, why it doesn't, and why it progresses very rapidly in some people. So likewise, there are a number of surprises with the CT and which we used to see in invasive angiogram. And this is another patient, a doctor. Sometimes we see the dilemma, we have the dilemma what to do for this patient. He is a doctor. In 2017, we did, there is mild lesion, and in 2021, there is almost 90% lesion in the LAD. The tendency or temptation is to do a stent, but we did not. We asked him to do the exercise. So he did almost 12 minutes negative. So now we know that it is not, especially when it is discrete lesions, the hemodynamic significance is not there. And some people have collateralization. Even, normal coronaries, there are some better collaterals for some people and not for some people. And I was talking about the risk factor stratification, all these risk scores, and many times the MI happens when the lesion is 30-40%, not the lesions 70-80%. the more number of 40% lesions are there. This is seen in earlier trials and even in the recent Scott Hart iconic trials, promise trials and all this. So as I was mentioning, again, CAD is an enigma, and by looking at the patient, unless you do personalized approach, you have personalized approach and have all the information, you cannot predict. This gentleman who was supposed to be very fit marathon runner, he died while running. That was in 1980s. But we never gave, and he had autopsy showed triple vessel disease, critical triple vessel disease, Jim Fix. And in the ICUs, same we see in our ICUs, day in and day out when we see, again this is the practice. Almost 70 to 80% of them do not have any significant risk factor to categorize them as a high risk. If we see these patients who are admitted the previous day in our outpatient department, we would say don't need the statin, you are less likely to get any heart attack. But then this is how the data, and that is how the prediction, almost you have 200 risk factors, apart from 6-7 major risk factors, 200 risk factors, and none of these could predict the occurrence of events till the other imaging modality. Now the coronary calcium and CT have become buzzwords, and because of this, despite using 200 risk scores, 50% of the patients across the globe who are using statins do not require. Either it is Europe, US, India, we need not tell, in a very, very irregular way of prescription. And another 50% is missed, even by the experts in the current guidelines. So, the statin usage, the aspirin usage in an individual who really requires, who will be benefited. Now, there is a lot of thought about it and how much dose, whether the patient needs statin, what is the dose, and for how long, when we should start statin, not after acute MI or at the age of 55, 60, 65, when they come to us. Now the concept is to start the statins early, 30 years, 35 years, when the cholesterol blocks are, spongy and then they regress with the statins, not when they get calcified, when they become hard. Statins will not help us. And now with the number of studies and the data accumulated over thousands of patients, calcium consortium, MISA, Masala, a lot of other registry data, all these things, now see, CAC and CTC have become buzzwords. When this paper was published, people were laughing. So almost 7 years ago, how is it possible to give a warranty for a heart attack? But this is what it is. Out of 9,000 patients who are followed for 14-odd years, the mortality or ASCVD events was less than 1% when the calcium score was 0. But it took a lot of time for the people to accept. Except UK, NICE guidelines in 2016 have accepted CT as the first line of investigation, and only in 2021 this is accepted globally. And then so, coronary atherosclerosis starts in some unfortunate segment, which it is our duty to identify which segment is developing this at early age, pick up, and then fix targets to address the risk factors. 120, 130 systolic blood pressure, 50 or 70 LDL cholesterol. So likewise, look at the lipoproteinemia, which is very common. We were supposed to be, after CAP, it is supposed to be one of the important risk factors in South Asian ethnicity. So address these after picking up and give reassurance if it is 0 even when the patients have 2 or 3 risk factors. Of course, you have to follow them carefully. The interesting story, in fact, CAT, when it was tried to be published, it was rejected. But you need sometimes, celebrities to promote. And when Trump got it done, there was a huge search in the Google for CAT. What is this CAT? What is coronary artery calcium? And all people started looking at it. So this is about the stress test I was talking about. 95% of the stress tests are normal, and the stress tests do not give any actionable information, because people who are referred for invasive angiogram based on the ischemia stress testing did not show significant difference in terms of obstructive CAD or non-obstructive CAD. So it is now pulled to the second line and directly look at, rather than guesswork, right, directly look at the coronaries, and only in patients who need stress test has become secondary in certain selected borderline patients where it may give some crude idea. Otherwise, it is not used, no more used to diagnose, not to advise or advocate the interventional procedure, whether PCI or CABG. So it should not be a routine part of health check, though. People ask, in fact, if you have a health checkup, if you remove the treadmill, I want to do a treadmill. That has become such an ingrained thing. These are all the landmark studies, almost since 2010, 2008, which were given, which were taken lightly for almost a decade or so. And then several studies, and then it is proven. And sudden cardiac death, calcium score in sudden cardiac death. If you see this, CAC more than 1000 versus CAC 0, the sudden cardiac death incidence, and then intervention. If you do intervention when CAC is 0 by giving statin, there is not much of benefit. Only as it goes up, the benefit number needed to treat is also less if the calcium score is more. So, like any other thing, it had to face a lot of resistance, all these CAC and CTCA for almost a decade. And American Society of Nuclear Cardiology, it was the toughest competitor for this, because that is most frequently used even now, and that is again functional and sometimes partly anatomical test, but with almost 5 times more radiation than CT coronary angiogram. Stress maybe, stress thallium, all these give much more radiation than CT coronary angiogram. This is how some of the patients where it has progressed in the past decade, our own patient data. Usually coronary calcium progresses 20 to 25% maximum per year. If it progresses faster, it suggests a fulminant disease pattern. So this is what I have been talking about, the 10 important messages from all the 8 societies across the globe have come together and gave uniform opinion, except the American Society of Nuclear Cardiology, which has walked out of this group, right? So in this acute chest pain, again, if it is low or intermediate risk with a heart score, CTCA or CAT, again, in Indian patients, these guidelines may not apply, what we have seen and what is being reported also in India. And stable chest pain, we used to do routinely invasive angiogram. Whenever a patient has a classical angina, we used to do invasive angiogram. Now we no longer do, we do CT angio, so that the disease could be peripheral, disease could be distal, it may not be, it may not need any intervention. So likewise, stable angina pectoris also. And then asymptomatic patients. So still guidelines are not there. I'll show you the data, Miami heart study and then SCAPIS registry. Almost 40 to 50% of the patients beyond the age of 45 have atherosclerotic plaques. The remaining do not have. And you can, reassure them, but this segment has to be addressed. That is the current data. And these are the guidelines which have developed over years. And this is what it is. For routine diagnosis, invasive angiography probably should be avoided based on the availability. And this is where not only diagnosis, then CT, FFR, once if it is available, it is a one-stop shop. And then you have CT myocardial perfusion, then the role of intervention also can be advised based on this. So not only the degree of stenosis, it is the proneness of the plaque or high-risk plaque, perivascular fat attenuation index, and then the plaque quantification or morphological description. Now Lehman's scoring system for plaque based on the location of the plaque, location of the calcium, if it is proximal or left main or in the proximal LAD, it is more dangerous compared to calcium score, which is distributed more distally, uniformly, not involving the proximal vessels also. So this is all the data you have. As I was mentioning, even if you have 3 risk factors, if the calcium score is 0, the prognosis is reasonably good, and even if no risk factors are there, if the calcium score is 400 and more, they have high ASCVD events. And even in younger patients, 32 to 46, we have initiated a program with the Rotary Club in Vijayawada as a drive in Krishna district to identify between 30 and 45 because one of the IAS officer's son died and he wanted to start a trust. So we are doing that study. Even if one risk factor is present, we are trying to do calcium score and if necessary CTCA or calcium score plus stress test. So that is how we are trying to see whether we can screen and prevent the sudden cardiac deaths. So again, smoking, and then this is a review of when the, a lot of analysis is there when calcium score is 0, and how depending on the burden, and calcium score 0, and lipoprotein, as I mentioned, is another one. The other data I was talking about, Miami study, and then the SCAPIS registry, which is showing significant incidence of atherosclerotic plaques in patients, elderly patients, probably in Indian patients. So that is much more because we are about a decade or decade and a half earlier compared to them. And then time of conversion, it is not known when it converts at the age of 35, 40, 50, we don't know. But once the calcium score appears, 20 to 25% growth, increase in the calcium score, there is a defined trajectory based on the age at which it appears. So that is what it is. You can guess what it is, but you must also know that even if the patient uses calcium score may become more, you should not get worried unnecessarily. It becomes more dense and then it makes the plaques more stable. So this is now, even then we were talking about a lot of the studies, HS, high sensitivity, CRP, CIMT, antibrachial index, fluid-mediated vasodilatation, all these things. When you do all these things also, even if all those are negative, the downshifting of the risk is only with the calcium score when you discount all these things. So this is also proven, and then the implications, cost effectiveness of statin usage and all these things, and then unnecessary side effects of statins, diabetes and all these things, and this is how it progresses. And the warranty period of calcium score in diabetic patients, if the patient has got symptoms, we repeat it every 3 to 4 years. But in a normal patient with no risk factors, even the warranty period is for almost 10 years. So depending on the symptoms and depending on the number of risk factors, you repeat it 3 years, 5 years, 7 years, or 10 years. And then statin, aspirin, so anything between 1 and 100, whether you have to give or statin, you have to personalize, but more than 100 it is recommended. And aspirin, again, more than 100, people say 300, there is a debate when you should give aspirin, but you have to individualize, and then based on that you prescribe medication. So it is the primary test with all the recent data, investigations, and also the lower mortality, 41% lower death and MI rate in CCDA than in standard care group, especially in patients who are suspected to have CAD. So standard is ischemia stress test or radionuclide stress test, and then layered testing, so-called, then time delay, and then 2-3 days, 4 days, then do the invasive angio, then FFR if necessary, and again try to reach a conclusion. So evidence now is very strong for this, the strongest negative predictive value, and this is all. Yeah, this is how it looks like. If it is normal, if it is borderline, when you do stress test, when you advise FFR, and then when do you advise clear revascularization. So this is again the data, lot of papers, lot of data, and then this is about microcalcification. In fact, the atherosclerotic plaque, there is microcalcification almost always. If the microcalcification is on the cap, on the plaque cap, it may rupture. If the cap thickness is less than 60 microns, it may rupture. So it is there, and over a period of time, the microcalcification coalesce and become, dense or a single plaque or sheet or nodule. And statins definitely increase the thickness of the atherosclerotic plaque cap, and it causes regression of the atherosclerotic plaque. Then it increases the density of the calcium. That's why calcium score is little more for statin patients compared to statin naive patients. So this is what diffuse and how it becomes, and FFRCT, all these things, and then it is more than the stenosis. You have a lot of other things, and then the radiation dose, one of the most frequently discussed in the past decade, that is high radiation equal to 100 X-rays and all. So it is wrong. In fact, for the past 12 years, with the iterative reconstruction, step and shoot, in fact, the radiation dose of CT angio is 50% of the invasive angio. This is what the data you have. You can see that, right? And the complication rate is almost even it is not 0.5%, but sometimes reactions, then air fusion, the drug spillage and all. So these are all the latest studies which show the superiority of these. And then troponin. Most of the practitioners do the troponin in chest pain patients. If the ECG is non-diagnosed, if troponin is negative, and especially 3 to 4 hours after the chest pain, then CAC or CTCA or CAC with stress test based on the age and your suspicion, low or intermediate risk, you do it, and then you tend not to miss the patients. So this is all about it, and nowadays many patients, many youngsters we are seeing, and they stick to the drugs once you show them the calcium. Otherwise, even in US, 60% of the patients stop statins even if they are prescribed and even if they require. But once you show this calcium or plaques, almost majority of them stick. They go for good lifestyle changes, exercise programs and all. So that is the other advantage of picking up the disease in early and then suggesting to them. So with all these things and all debates, what are happening, medical management, PCIs, CABGs, a lot of conferences we keep seeing. So a lot of things happen, a lot of things appear in the market. Immediately the pharma guys are after us. You start this, start that, it is proven and all. But we use our judgment, utilize your experience, and then don't jump immediately. We always, restrain ourselves to have real world data and then apply the personalized, medicine or therapeutic applications for the patient. So this is where I stop. I don't know whether there is some time for any questions, because this is quite different type of practice which I have done for almost 30 years, and in the past 4 or 5 years I have changed my concept strategy of addressing the patient when I see in the OPD or when I see in the emergency room, or after looking at the anatomical lesions also advising about the therapeutic modality, intervention. We have heart team approach and all, but we are more cautious, and judgment is sometimes very difficult. There are certain gray zones as microvasculature and certain really high risk blocks, how to identify, and certain things which are still, and then non-obstructive disease, MI or ischemia with INOCA, MINOCA and all these things, how these are there in female patients, non-obstructive disease, how it acts. So a lot of gray zones are still there, but whatever it is, with the available data, we try to individualize the management of each and every patient who come to us. So thank you for patient hearing.
The experience of the man has spoken. Really has captured. Thank you, sir.
Good evening, everybody. Thank you, Nishant, Pawan, and Chandramouli, to give me this opportunity to stand before you and talk about a few things which are of interest. Before I start, at least in the last 30 years of approximately 28 years of my cardiology practice, and especially the recent, the non-invasive assessments of coronary heart disease. The best possible quality CT coronary angios are from Dr. Ramesh's hospital. So I keep saying some of his work, some patients who travel from Vijayawada to Vizag, and they come up with some kind of a data with the films and all that. But I must really acknowledge that quality in your hospital, sir. It is wonderful. Thank you so much for that kind of expertise and then that kind of a resolution that you have brought into your coronary calcium and coronary angiograms, non-invasive. So, moving over from anatomy to the physiology and functionality in coronary heart disease. Though the name was very catchy for the sake of some kind of a zinc that they wanted to bring in. Basically, what we are trying to address here this evening in the next few minutes is speaking about a little bit of ischemic left ventricular systolic dysfunction. See, worldwide view, we all know that the IHD is increasing, and from 1990 to 2015, it is almost 75% of the increase in the IHD world over. And among all the IHDs, if you take 30% of them will ultimately culminate in heart failure. Right from our undergraduate times, from the first clinical years, we have been hearing about heart failure and heart failure syndromes in terms of the so-called clinical signs and symptoms. I don't have to talk anything about the heart failure, but except to say that a very large chunk of acute MIs will ultimately evolve into heart failures, and that's why there is an increasing burden of heart failure in our community. This is due to increased survival and overall aging of the population, and of course the increased morbidity and mortality attendant with that particular heart failure is greatly increasing in our society, and we are increasingly getting called to deal with this kind of an epidemic of heart failure in our community. So whenever we are talking about heart failure is not just one single entity. It encompasses a lot of pathophysiological substrates. And whenever we are talking about heart failure now, we have the first thought that has to come into every practicing cardiologist and physician whenever they are seeing a heart failure patient in their offices, whether there is some amount of viability in that particular heart failure syndrome. So what do we mean by viability? To put it in a clinical spectrum, it is a dysfunctional myocardium, but it has a potential for recovery. The myocardium is not totally dead. There is potential recovery if some things are done. So that is what the viability is all. And if you look at the pathophysiological aspects of that, there is a cellular and then metabolic and microscopic viability, a contractile function we are talking about. So to put it in a nutshell, whenever we are seeing a heart failure in our clinics or in the emergency rooms, that kind of a dimension should automatically come into your mind. Okay, this is the heart failure syndrome, and how much of it is viable, how much of it is retrievable, how much of it is potentially reversible. That is a thought process that we all should develop. So there is a lot of heterogeneity about the viability. There are several terms that are used by the cardiologists and by the cardiology community in the heart failure and viability. We call it, we name it as stunning, we name it as hibernation and stuff like that. I don't want to go into the details of that. I'll just give you one small simile. The people of my generation, probably the youngsters here wouldn't really understand what I'm going to say. When we were like you, the voltage fluctuations in our homes are significant. Like, for example, we are sitting here, there is a bulb there, and then suddenly the electricity, the voltage comes down from 220 volts to it just comes down to I don't know what, because there is no measure at the time. Suddenly, when we are, reading or whatever, the bulb, instead of 45 watts, the bulb will start glowing only at 20 watts now. The voltage comes down, the supply comes down. So the myocardial stunning and hibernation is something like that. When once the voltage, the electric supply comes down, the bulb becomes little down. So the myocardium also, when once the circulation comes down, the myocardial contractility will come down. There it is a question of electricity and the filament. Here the question is about the myocardial blood flow, the coronary blood flow, and the myocardial cell, which comes down in its contractile function. Now, if this particular process goes on and on, the myocardial contractility in the cell dies, and then it gets replaced by a fibrosis. But it is not instant, because the myocardial blood flow through the coronaries is never a kind of a stop or stopped. It is not totally stopped, it is not totally starting in full. So there are periods of start and stop, start, stop, kind of a myocardial blood flow keep happening in the coronaries. So with all those insults, the myocardium will go into a kind of a shock state. And then some amount of it is completely dysfunctional, some amount of it is fibrosed, and some amount of it is viable. So the contractile function is a mixture of all the things which we call by several names, only culminating if it is not addressed in time to in the form of fibrosis and contractures and completely dead muscle. So that is all the viability is all about. So then once we know that yes, there is an element of viability in all the heart failure patients, then how are we going to recognize it? There are several modalities, but before we go to modality, what are the implications of viability assessment? Does it really matter at all? See, the problem is the viability imaging has far-reaching implications in a few instances. For example, because we thought that there is some amount of contractile function which can be restored, it can really result in an improved, morbidity and mortality. Not only that, the morbidity and mortality related not just about the myocardial pump failure, but also we can reduce the burden of ventricular arrhythmia. And then, with all its attendant risks, then once the arrhythmic burden is reduced, then the possibility of sudden death also comes down. So those are the implications of viability. So how do we go about doing the viability imaging? There are several modalities, starting from the electrocardiogram. See, we would try to look at or correlate the presence of a Q wave in the resting electrocardiogram, and then understanding whether it is viable myocardium or not. But then, initially when we were students in medicine, when we were students in undergraduates, and then partly when we were students early times on DM cardiology, the Q wave invariably meant a dead muscle. But then now we know that it is a very, very low sensitivity and low specificity whenever you see a Q wave and try to correlate with the viability. So don't ever think that a Q wave presence in the surface ECG is automatically means it's a dead myocardium. It is not. Then the second issue is about the stress test. The stress test, for example, is done in a patient who has had a myocardial infarct, and there are Q waves in the surface ECG, either in the anterior leads or inferior leads, wherever. And then you find that the ST elevation, that is the segment which people try to correlate with the viability. It is not as low a sensitivity as Q wave, but ST elevation in a Q lead is associated with some amount of viability, though it is not a perfect science. Again, the correlations are only modest. So likewise, ECGs are looked at to try to correlate whether there is viable myocardium or not, but then it is not a very foolproof methodology. Then people moved over to echocardiograms. Typically, in a post-MI situation, if the LV remodels, LV actually is a prolate ellipsoid shape. For the maximum mechanical advantage for the adequate cardiac output, you need the prolate ellipsoid shape for the left ventricle. Any change in that shape is called remodel. Then once the myocardial infarct takes place, this LV changes its geometry and it starts dilating. As you see, the 1 week after the post-anteroceptal MI and then 3 months after post-anteroceptal MI, you see that there is a lot of change in I don't know whether you're able to appreciate or not, but on the right side, the change in the geometry is very visible, very clear. So this is called remodeling. So non-viability is assessed basing on a severely dilated left ventricle, or in echocardiograms we arrive at or we gauge what is the end systolic volume. That is the volume of the blood that is present in the left ventricle at the end systole. If it crosses 130 ml, it's significantly non-viable. Or one of the most important surrogate point or a metric for non-viability is any end diastolic wall thickness of the left ventricle. If it is less than 6 millimeters, it is supposed to be non-viable. So again, there are sensitivities and specificities that go with it. Not foolproof, but at least better than just an electrocardiogram. Then some specialized procedures have come in the echocardiography itself. These are all the imaging modalities for viability. We do what is called a dobutamine stress echo, in the sense that echocardiograms are done and then we inject the continuous infusion of dobutamine at a very small dose to start with, at least by about 2.5 mics per kg per minute, and then you give it for about 3 minutes, increase it to 5, increase it to 10, increase it to 20, something like that is cascading and accelerating, increasing doses, and then you see whether the myocardium, how it is responding. There is what is called biphasic response in dopamine stress course. Biphasic response is the moment you give a smaller dose, that is 2.5 or 5 or 10 micrograms per kg per minute. The initially non-contracting myocardium starts contracting. And as you go on increasing the dose of the myocardium, dopamine to say 15-20 micrograms per kg per minute, the previously well-contracting myocardial segment will start again, go back into a kinetic mode. That is called a kind of a biphasic response. So this means the myocardial segment, which is akinetic, which starts contracting when once the dopamine started, it is viable. But it is not really sustaining that viability because there is no flow into that area. And dopamine, when you are increasing the dose, the myocardial oxygen demand goes up, not matched by the perfusion. So it just goes into a kind of a kinetic state. This is called biphasic response, and this is one of the most important features of viability in non-invasively. There are other additional echo parameters like tissue Doppler imaging, strain and strain rate imaging. I don't want to get into those arenas because it's quite a complicated stuff. So we move over from the echocardiogram into nuclear scintigraphy. So there are two modalities in nuclear scintigraphy. One is called a SPECT, and second is what is called a PET. In SPECT, you try to assess the ischemia essentially, because if you see the image there on the top panel at the almost from 4 o'clock to 6 o'clock position, there is a kind of a no signal at all. So that is the stress image during SPECT, wherein the myocardium is not receiving the blood during the stress, which means that that particular area where the blood is going is obstructed. There is no flow there. So that is why that signal void is seen. But then imagine the same signal void at the rest. So that is the infarcted myocardium. Now you want to know whether this infarcted myocardium is really viable or not. SPECT doesn't really tell you. Then you go for what is called a PET. PET is a kind of both perfusion as well as metabolism. Both are studied. Again, the perfusion is assessed by ammonia compound, which is nitrogen tagged, and then the metabolism is known by glucose metabolism. Glucose is what is fluorodeoxyglucose. So you combine both and then arrive at whether there is adequate perfusion or reduced perfusion, and whether metabolically it is the myocardium is alive or not. So this is the most specific and most sensitive tool in the present day in non-invasively for development or for diagnosis of myocardial viability. Last but not least is the cardiac MRI, which is very user-friendly, extremely reproducible. The inter-observer variability and intra-observer variability that you see with Doberman echoes are not there with cardiac MRIs. Cardiac MRI is the most sought-after tool for myocardial viability assessment tool. In fact, we all advise cardiac MRI for diagnosis of viability. So, in segmental thickness is one of the metrics that you look at in the cardiac MRI for knowing whether a myocardial segment is alive or not. As I said, it is end-diastolic wall thickness. If it is less than 6 millimeters, it is not supposed to be viable. Cardiac MRI is. But if it is end-diastolic wall thickness is more than 6 millimeters, then it is high probability that that particular myocardial segment is viable. Then the second aspect of cardiac MRI is what we call as late gadolinium enhancement. That is, gadolinium is a kind of a radio contrast media which they apply in the MRI. They inject the gadolinium and then image the MRI in 15 minutes or 10 minutes, depending upon the type of the sequence that they do. But typically, in 10 minutes' time, they just image, and this is what they see. On the right side of the panel, if you really observe, there is a white, an arc on the right side. This is where from here to here. On the left panel, from almost 4 o'clock to 8 o'clock position, there is this white band. So late gadolinium enhancement is this is what the late gadolinium enhancement is. So the gadolinium it accumulates in the extracellular component, and then it becomes kind of a whitish image is what that is given. So this is the scar. Whereas the rest of the myocardium is all signal void in the MRI. So in LGE study, for example, if you see this, it can be spread over a subendocardial area in this area, or it may get into the partial thickness scar, which involves only 50% of the myocardium, or it may be full thickness scar, the entire myocardium. So depending upon the actual percentage, the actual viability happens. If it is just 25% of the myocardial thickness, it is still a viable and retrievable myocardium. If it is more than 75% of the myocardial thickness and LGE is positive, then it is not likely to be a viable myocardium in total. So here you see there is a full thickness myocardial scar starting from 7 o'clock or 8 o'clock to almost 1 o'clock. So in this kind of a patient, supposing if you, whatever the coronary anatomy say, whatever the coronary angiograms say, you try to revascularize that particular patient, you are not going to gain anything out of it, because this segment is totally dead. Whereas this is subendocardial scar. This whole thing is still viable. This particular scar is subendocardial. This part is subendocardial. So there is good amount of viability in that area. If the coronary artery segment is supplying these areas, which is usually the red, this is the bullseye and this is the LED territory. If the LED has significant block and you try to revascularize or reperfuse, then this patient's thin node segment also gets improved. So this is what the viability based upon MRI. So you have the concept of viability, you have the metrics of viability. What is evidence based for ischemic left ventricular dysfunction? There are several studies which have come up as late as 2022. The last and the most important study is what is called STITCH, and revived BCIS is just published or just reported in the Europe ECR. Not Europe ECR, it is European Science of Cardiology. So that is where it is published or presented. So here, all the studies are trying to address whether the patients get ischemic left ventricular dysfunction, will get benefited by the medical therapy or revascularization. STITCH trial, they did not really specifically look at the viability. As a generic left ventricular dysfunctions with multivessel disease, they went ahead and then did CVG and compared it with that particular segment. Another segment is goal-directed medical therapy, only medical therapy. So the STITCH trial is a kind of a extremely, troublesome trial for us, because it showed goal-directed medical therapy and CVG results are same. There is no difference at all. But here the catch is goal-directed medical therapy should include beta blockers and all the therapies or all the proven therapies for heart failure in the proper doses. Whether it is beta blocker, whether it is ARNI, whether it is inhibitor, whether it is aldactone and statin. All the drugs in their proper dosing should be there, should be on board, and then whatever you get the benefit out of CABG and benefit out of medical therapy are going to be the same. So there is no change. That way STITCH become totally disruptive in our practices. Coming to revived, they looked at CABG in STITCH. Whereas, what about the PCI? What about the stents? The revived study just presented in the 2022 again showed there is no difference between the dual-directed medical therapy and multiple stents. So, in other words, ischemic left ventricular dysfunctions, whether you do CABG or a PCI, versus a significant amount of goal-directed therapy, appropriate goal-directed therapy, the outcomes are not going to be different. But then there are caveats. Always, it is not a foolproof 100% statement or 100% position that we can take. As a generic, segment, we can just say properly, treated patients with medicines, the outcomes are almost equal to a revascularization strategy. we will look at the caveats. Though, why this particular issues have come up? There are several assumptions that we have, like any other general assumptions that you have. So, in a viability, the first assumption is that the contractile function will improve with revascularization. This is the first assumption. That for any doctor, for any lay person, the contractility will become better once you revascularize. The second assumption is there is improvement in contractile function will result in improvement of ejection fractions. That is a common sense, stand that we all take. And the third assumption is that you have improvements in ejection fraction will definitely reduce the adverse effects or adverse outcomes. This is the third assumption that we see. First, about the improvement in contractility. The problem with this particular assumption is that whatever the data that you have, basing upon the previous assumption, that is improvement in contractility, all the data was observational or the registry data. They are not randomized trials. There are so many other caveats in this particular observational data. Some of the patients did not have medical therapies. You will be surprised to know that a good number of 40% of the patients did not have a beta blocker on board whenever this kind of assumption is made. So, in other words, if there is a suboptimal medical therapy and you assume that there is improvement in contractility because of revascularization, that's not an assumption. That's not a assumption which is worth really be convinced about. Because beta blocker has to be there for you to have a kind of appropriate assessments. Another important issue is there are so many other confounding factors, like for example CRT. For example, CRT is there and cardiac resynchronization therapy is there. And then you have a bundle branch block, a left bundle branch block, you have all the medicines on board and you gave CRT, and in that particular patient, your revascularization may not have improved the contractility at all. So these are the assumptions, this is the assumption basing on so many suboptimal assessments, and so the first assumption is not totally correct. Second, improved contractility leading to better EF. You will be surprised to see, if you look at the STIX trial, the mean improvement in ejection fraction was only 2% at 4 months. Supposing if 35% is the cutoff, or less than 35% is the cutoff of all the ejection fractions in STIX trial. So when they are following up, in 4 months' time, from 35 or 30%, the ejection fractions have improved to about 32% or 34%. And at 24 months, then EF improved by only about 10%. So the viability and the contractility improvement with revascularization automatically leading to ejection fractions is not a rule. Hence, the third is whether the improved ejection fractions have really translated into mortality. EF improvements will lead to the deaths due to pump failure. EF improvements will not lead to reduction in the arrhythmic deaths. So if you really plot the ejection fraction improvements and then the death rate, they go hand in hand as far as the pump failure and then brady arrests are concerned. But as far as the tachyarrest, like arrhythmic death and the acute MIs, the ejection fractions are not associated with increased or improved mortalities. So in other words, these are the various problems or the confusional states that the data has really thrown up once we started studying it. So how do we proceed? On balance, the revascularization reduces mortality in ischemic left ventricular systolic dysfunctions and a substantial volume of viable myocardium. That is a balance. So here the issue is that you have to have viable myocardium, but a very substantial amount of viable myocardium. Then revascularization is going to be of that. If it is only about, say, 10% of the viable myocardium, or any metric or any quantum that we are talking about, we're going to look at it, and as against 50% of the viable myocardium, there is a lot of difference. So, in other words, it is not a rule that all revascularization procedures should be attempted in all patients in whom the viability is limited. So it is not going to really translate into a significant mortality benefit or ejection fractions or survival benefit or contractility. How do we know substantial means what? Substantial is, for example, if there are segments of echinacea and dyskinesia, you only focus on the third part. If there is an echocardiogram with echinacea or dyskinesia and the LGE is less than 25%, the actual myocardial thickness of the scar is less than 35% or less than 25%. Another way of saying, if there are typically now depending upon the echocardiograms and scintigraphies, we identify and we recognize 15 myocardial segments generally. This is the standard of assessments. Out of 15, for example, if less than 4 are viable segments and your end systolic volumes are more than 130 ml, that is a worst case scenario, nothing is going to happen. The patients are not going to get benefited even if the patient has a multiple triple vessel disease, critical triple vessel disease. Your revascularization is not going to help that particular patient. As against, if there are more than 4 myocardial segments which are viable and your end systolic volumes are about 130 ml and less, then that is a segment where the revascularization is going to really make a lot of difference to the patient's outcomes. Irrespective of whether the ejection fractions are going to go up or not. Ejection fraction may be still remaining about 35% or 40% or whatever, but there is a lot of improvement in terms of both pump failure as well as the arrhythmic death as well as the peri-infarct or the acute which can happen in the viable segment. So, to sum it up, what is the status position? For example, if the coronary angiograms show a revascularizable, the coronary anatomy, and you have evidence of ischemia in that particular myocardium, then you have to go for revascularization plus goal-directed medical therapy. Supposing if there is no ischemia, there is no question. You just have to go for LGE by CMR and then extend to the scar you measure whether it is less than 25%, 25 to 50% or more than 50%. And then decide about whether it is revascular, whether you should send for a revascularization or not. Supposing if it is borderline 25 to 50% in LGE, then you have to look at your contractile reserve or metabolic reserve by scintigraphy or by double stress echo and then understand what it is and then decide about the revascularization. So, to sum it up, the most important take-home message is that first and foremost thing is whenever there is a heart failure syndrome, you have to keep in mind that there is an element of viability in that particular syndrome. So, the digoxin to start with, if your prescriptions in your either OP cards or in your case sheets, if you start with digoxin, then you're not updated at all. So the prescription should start with the beta blocker, and again, evidence-based medicine. There are only a set of beta blockers which are studied in heart failures, not all. Bisoprolol, metoprolol, carvedilol. Similarly, ACE inhibitors, ramipril, enalapril, mostly ramipril is better. As far as ERPs is concerned, telmisartan is not studied in heart failures. You have only valsartan, you have losartan, and then you have candesartan, which is not available anywhere. Or even olmesartan also is not studied is not attempted in heart failures. It may be class effect, but then it is not an evidence-based molecule to start in heart failures. So, likewise, your approach to a given individual should evolve for a ischemic left ventricular dysfunction and heart failure syndromes. Thank you.
I will just ask each of you to just comment on this question. There is a need for very specific guidelines for Indian population. Sir was talking about ethnicity and race with regards to CD calcium scores. And the boy was asking about our local drugs and kind of. Are we actually justified?
We have been, mostly blindly following the data, the guidelines, what you're talking. If you talk about all these risk scores, what we're talking, these are not applicable because majority of the represented population is not Indians except masala study and all that. So the South Asian ethnicity itself has got almost some 2.3 times higher incidence of coronary artery disease, just ethnicity. And again, in the South Asian ethnicity, the countries, if you take, so whether Indian, South Indian, North Indian, whether there is some difference. And then there are some studies to show that there is genetic variance in even in the drug-drug interactions like anticoagulants, antiplatelets, compared to Caucasians. So likewise, for example, in India you have, I think, for diabetic, Indian Diabetic Association is there. It has got a different set of guidelines with regard to even recommendations for A1C, accepting a little more. BMI is less compared to the recommended 25, 24 it should be less than 23 or something like that. So likewise, definitely in cardiology, you need to have, and that is how I think all of us have, most of us have EMR now. With that data, some people come together in different areas. Like in fact, we have been participating in these FDA approved studies since 2006, almost 20 studies or so. So they are doing some genetic studies also, I believe, but we don't have the data yet. But Himaja is here. We are trying to start with Himaja taking active role. Genetics like protein A. Now a lot of things have been talked about. Metabolomics, metabolomics, something which is coming up, and other factors we don't know what combination. And then family history. She's making a list of family history. Family we see very frequent, right? So there is definitely genetic predilection. So Indian guidelines need to be there, and we are of course following. And for example, I tell you, Milinon we give, right? Milinon, what we start is only 1/4 of the dose that is recommended, and we never see ectopics, but within few hours we find improvement in clinical hour, try compared to. So likewise, we try to indigenize, and then we try to do best study, so not recommended.
The reason that I asked the question was optimizing the dose of guideline-directed medical therapy basing on the Western doses to the Indian population may be slightly difficult.
Actually, I leave it open to the next generation. You guys, next generation, are very enthusiastic. I personally feel that there have to be some kind of a histories across the entire Andhra. At least, you can just take up that idea, because the idea of history is also for Indian data. At least some kind of a guidance like this. Whether to start, what kind of a dose, what drug, stuff like that. The most basic risk factors for ischemic heart disease, coronary heart disease, whole cohort equation is easily implementable here. It's not a big deal. It's just that we don't have the data at all.
I've been practicing in this town, I would say town because the present government has classified all the big cities and small cities as Tier 3 cities in Andhra Pradesh. So I've been practicing here for the last 23 years, and with one cardiologist in town. I always dreamt of not having to send any patient out of this town for further need in cardiology in those times. And we at Trust Hospital have successfully managed to keep back patients in cardiac patients, more importantly, by providing every treatment modality in cardiology. So I would like to congratulate our cardiology team, Nishant, Chandramouli and Pawan, for putting their minds and heart and soul in cardiology, and along with them Dr. U. Ramakrishna, who's been supporting them very ably with his surgical talent. So and apart from that, we at Trust Hospital have also managed to keep back most of the patients in all specialties except oncology. So as a team, we are delivering the best of care that is that we are able to do here. And with regards to the CME, we at Trust Hospital also believe in practicing evidence-based medicine, and we've been planning to do CMEs like this, and our Department of Cardiology has been pushing us for this kind of CMEs over a period of time, and the results are to be seen. Thank you.